Welcome to the Uzima Health and Wellness Podcast. What did the doctor say? Okay, so I'd like to welcome you to the Uzima Health and Wellness platform, Dr. Vinay Tubman. And I'm so excited to meet you. And I've read all about you, but I want to, this is in celebration and recognition of Sickle Cell Awareness Month. And you are a renowned leader in sickle cell research. And I would love to now have you talk to me about your journey to be a pediatric hematologist with a specialty in sickle cell anemia research. So we'll break that down, and welcome to the platform. So tell me, Dr. Vinay, how did you get interested in medicine in general?
Oh, well, Dr. K, first of all, thank you so much for having me. I'm really excited to be part of this platform and be part of this effort today. And it's wonderful to meet you and to speak with you in this time, and especially for this reason.
Thank you.
So my journey to medicine, I remember way back in middle school doing some middle school science project where I started to learn actually about blood banking. And I just thought blood banking is really interesting, and blood typing is really interesting. Maybe being a doctor would be really cool.
Oh, wow.
Yeah, so I was fortunate in that I ended up getting routed to a high school that was a magnet school for science and technology. And I did well there, and was able to then go to Harvard for college.
Wow.
Just a phenomenal experience. I truly enjoyed being there. And while I was there, I studied chemistry because it turned out that I really loved science.
Okay.
And I got into this project that actually started looking at the biology of red blood cells.
Wow.
And I got into that project. I said, well, I want to learn about people. I want to be a doctor, because at that point I knew that I wanted to be a doctor. And so I was able to do a project at Boston Children's Hospital. I connected with some physicians at Boston Children's Hospital, and they had me do a project which involved me reading through the medical charts of a lot of children with sickle cell.
Oh, wow. Wow.
And as I read through these charts and felt like I was kind of getting to know a little bit about these patients and these families, I mean, they were in the emergency room all the time for fever, for pain, for just all these different complications. I just got fascinated by the disease. And even as a college student, I felt, there has to be something better than this.
This is interesting. Because one thing I want to stop you and say, you went to a targeted school for science and technology.
I did, yes.
And so did I. I went to the High School for Health Professions in Houston. So I think that one thing that is important is that schools are early tracking of children or youth into a certain area is a good thing. And so I think that that's number one, something that I took from you is that early tracking and beginning to focus. What year was it that you got this awesome project in college?
This was my senior year of college. Between junior and senior year, I did this independent study that led me to look at the biology of red blood cells. And then I folded that into another project in my senior year, which led me to look at the clinical side of red blood cells, which was sickle cell.
How did you apply to college? I mean, what were the steps? I mean, apply to medical school.
So as I applied to medical school, medical school is such a phenomenal experience, and it is hard. It is hard. And I absolutely wouldn't trade it for the world, but it's hard.
Yes.
So I really wanted to be near family and in a place where I could have social and emotional support.
That's a good point.
At the time, I really thought about who I am as a learner. And all of medical school curriculum are very, very similar, but the way different medical schools approached adult learners was very different at the time. I think a lot of them have kind of moved more to more similar curricula, but I really wanted a medical school where I knew that I would get great education in medicine. I also wanted I mentioned my background was coming from science. And so I wanted some place that I could also do some research.
Okay.
As a way to further medicine, as a way to really lean into some of the more challenging questions of why are things the way they are and how can we make them better?
So you went to Harvard undergrad
Mm-hmm.
and Harvard Medical School?
Then I went to University of Pennsylvania in Philadelphia for medical.
Oh, for medical. So you had a very urban medical school experience. So in Philadelphia. Oh, I think
I'm sorry.
I says we had
a very
urban medical school with an urban population medical school experience. Yes. And that's something that people have to take into, and take into account. So you were in Philadelphia. There's some unique things about Philadelphia's population in terms of the Black population there. They have a large, very what do they call what's the population in terms of Philadelphia? They are very concentrated in certain parts of the city, and so you got to see a lot of pathology. Is that correct?
It is. There are several medical schools in Philadelphia. I think there were 5. And so we were in one part of Philadelphia near the university.
Okay.
It was all, I mean, the whole city is very, very urban. But different pockets of the city, there were large concentrations of Black people, and they tracked to different hospitals. One of the hospitals that served the West Philadelphia neighborhood, which was largely Black, was the University of Pennsylvania Hospital. But there were other hospitals that served that population as well.
Now, where are you originally from?
I grew up mostly in Northern Virginia, in a city called Reston, Virginia. And I feel really fortunate to have grown up there. I'm a Virginia girl. Virginia's for lovers.
Okay. And that's what's so special about your family, because I'm noticing the cheeks and the beautiful skin color. So as we say, brown girl magic, Black girl magic.
Thank you. I like to think I'm the Liberian girl that Michael Jackson wrote a song about. Well,
wow.
Exactly the song, but my parents are from Liberia. My family is from Liberia.
Okay, beautiful. And you've been able to go back and be there.
I have. That's truly been a blessing and a surprise in my career. My family left Liberia shortly after a military coup affected the country, and they left for safety, thinking that they'd be able to go back within a couple of months when things settled down. But I wasn't able to return for 27 years.
Oh, wow. For 27 years.
Yeah. And when I was eventually able to return for the first time, I went while I was in residency. And I had an opportunity to work at a hospital there. And I just, it felt at home, and it was my home, my family. I still have family there, and was able to really integrate that work into my career path.
And your career path, you've been studying and treating families with sickle cell disease, basically since you been involved in their care since college. So let's tell me about sickle cell and the disease. I think that we take for granted that these patients are okay, or that this disease is conquered. And so I was amazed at all the research still going on about sickle cell. So please tell us first, what is sickle cell disease? And let's then walk it through some of the challenges of the research.
Sure. So I have to say, having trained in these urban centers, and particularly in a city like Philadelphia, that had a large Black population, I had access to a lot of patients with sickle cell disease. I also had phenomenal mentorship in one of the pioneers of sickle cell disease research in medical school. And so really had great orientation to the disease from the outset. So when I then left Philadelphia and went back to Boston to train in pediatrics and then to train in pediatric hematology, this was always my focus.
Oh, okay.
So sickle cell disease is an inherited blood disorder that causes red blood cells to take on an abnormal shape when, in certain conditions in the body. We think of it as it is a blood disorder, but because blood goes everywhere, it affects all parts of your body.
Mhm.
At the in the very early stages, one of the changes that sickle cell does is it affects the insides of your blood vessels. And
Mhm.
so this creates a state of chronic inflammation.
Mhm.
Um, and one of the most common manifestations of sickle cell disease I alluded to earlier is this recurrent, severe, unpredictable, and difficult to control pain.
Mhm. Mhm.
So we've made amazing strides in sickle cell disease over the last 30 or 40 years.
Mhm.
Whereas in Africa now, and even 30 or 40 years ago, sickle cell disease was a disease that was often fatal in childhood.
Yes. Okay. Okay. 30,
Um,
40 years ago. So in the 70s or like 50s, 1950s, you saw a high infant mortality rate.
Absolutely, absolutely. So, we can talk about some of the evolution of sickle cell disease research, but we came to understand that a lot of these complications of early deaths from sickle cell disease were related to infections,
Mm.
and that we could prevent that with using vaccinations and using infectious prophylaxis or giving kids antibiotics to prevent infections before they happen.
Oh, okay.
But what probably one of the most important interventions was actually newborn screening.
Oh, okay.
This was recognized in the 70s, 80s that if we could test all children who were born for sickle cell disease,
Mhm. Mhm.
we could then intervene earlier than if we waited until they had their first complication to make the diagnosis.
So when we did the sickle cell screening at birth, we made that basically a public health policy, would you call it? And
Yes.
so when you say intervene earlier, are those children, is there something, those infants, is there anything different done immediately? Or are you just tracking that this baby was born with sickle cell and we need to monitor them closely? What happens if your baby is deemed to be sickle cell positive? That's different.
Yeah, so if your child is born with sickle cell disease, you should be referred to a pediatric hematologist if that's available to you, or to someone who's knowledgeable about sickle cell disease. The
Okay.
goal is to get these children on antibiotics before 2 months of age.
Oh, okay.
Because we start to see some of these infectious complications between 3 and 4 months of age, and we want to be ahead of that.
Yes.
So the goal of newborn screening is to really get these kids on antibiotics, and also to start the education
With the-
with the parents. I think empowering parents to help their kids
Mhm.
have a great life with sickle cell disease, empowering parents to have knowledge about sickle cell disease, so that they can be proactive, they can get ahead of the disease always,
Mhm.
is so crucial to survival.
Wow, that's amazing. So how many babies in the US are born each year with sickle cell? I have some numbers versus in the sub-Saharan Africa numbers. Do you have those?
So in the US, roughly 2,000 to 3,000 infants are born with sickle cell disease per year.
Okay.
Now, the sickle cell disease has actually been, I think, from a science perspective, there's some really fascinating components to it. So sickle cell disease, in order to have sickle cell disease, you have to inherit 2 genetic mutations or 2 genetic abnormalities.
Okay.
If you inherit 1 genetic abnormality, you have sickle cell trait.
Great.
And for the most part, sickle cell trait doesn't cause symptoms, although there's actually an evolving area of research that really is starting to understand sickle cell trait in a different way. But one of the interesting things about sickle cell trait is that sickle cell trait makes it less likely that you will die from malaria in childhood.
Okay, less likely. Okay.
Less likely, yes. So whereas in many parts of the world, historically, malaria has been one of the leading causes of childhood death, including in Africa, then sickle cell trait has persisted almost in a way to protect people.
Yes.
Right. So when you think about places where malaria is common, obviously sub-Saharan Africa should come to mind first and foremost.
Mhm.
But then we also think about Southeast Asia and particularly India. We
Okay.
think about the Middle East.
Okay.
Even there used to be malaria in the southern parts of Europe, in Italy.
Mhm.
We think about even malaria having been in some parts of South and Central America a long
Mhm.
time ago. It's much less likely now. But so in all of those places, this hemoglobin S, the mutation, genetic mutation that's causative for sickle cell disease,
Uh-huh.
evolved, and in many of those places persisted.
We had malaria actually in the United States. I understand that some part of the discovery and interest with sickle cell was due to the high rate of malaria in Memphis, Tennessee, and that they were researching these children out of there with similar pictures of fever, muscle joint pain in Memphis in the 1930s. And then they couldn't distinguish that from a sickle cell crisis versus malaria. Did you ever hear of those stories of malaria in the US?
I know that there has been malaria in the past in the U.S.
Mhm.
And so the one of the in that time, I think in the late 1940s, 1950s, there was also some migration up
Yeah.
from the Caribbean and from South Central America. And as
Mhm.
we started to get more people people of color, as it turned out, who had been exposed to malaria,
Mhm.
such that the genetic mutation could persist, we started
Mhm.
to see more kids with sickle cell disease. And
Mhm.
this is how it started to actually become understood.
Now, you said there are about, on average, 2,000 births for sickle cell in the entire United States.
Mhm.
And you're in Houston at a place that has a well-funded sickle cell clinic.
Absolutely. So presently I am the co-director of the Sickle Cell and Thalassemia program here at Texas Children's Hospital.
Okay.
And we're probably one of the larger, we are one of the larger pediatric sickle cell programs in the country. We serve about 1,200 kids with sickle cell disease just at our center alone.
That's amazing. And so your center, in terms of um, the functionality of it, you have your own independent emergency room, and do you have your own independent offices for clinics for just routine primary care? Do you separate these kids out even for their routine primary care and emergency room visits?
So we are a freestanding children's hospital. So everything in our hospital is geared toward the care of children and families.
Mhm. That's
Um,
wonderful.
we do have we have an emergency room that in our emergency room, children are seen for a variety of complications, for any complication. But because of the size of our our population of children with sickle cell disease, our emergency room is very attuned, and we work very closely with them in the hematology program to make sure that they're up to date and current, and also pushing the envelope to try and make care for kids with sickle cell disease better.
That's very important, because for the most part, if you're not, as a family, presenting your child to a place that recognizes sickle cell disease, can you talk about some of the challenges these families have with getting their children care if they don't run into someone like yourself, or into a center like the University of Texas Children's Hospital, and they're fortunate to have this type of compassionate care and knowledgeable care about sickle cell patients? What are some of the challenges?
I that would take another hour to talk about.
Well,
But I'm fortunate and somewhat biased that, again, I've trained in all of these places, and
Mhm.
my entire career has been in these places where there is so much sickle cell. So sometimes it's hard for me to imagine that there are many hospitals, and even the majority of emergency rooms in the country, there are people who have not seen a person with sickle cell disease regularly.
Mhm.
Um, Sickle cell disease can actually begin to manifest as early as 6 months of age, and sometimes even
Mm.
earlier. Often the first manifestation is pain,
Mm.
some form of pain. And so these infants, they need pain management that's appropriate for sickle cell disease, just as any other child
Mhm.
with sickle cell disease, or child or person with sickle cell disease needs.
Mm.
So I always encourage the patients who see me to, if they need help, wherever they are in the country, wherever they are in the world, before they go to an emergency room, call me. And let me know where they're going so that I can be I can assist the person that it might see them if they're not familiar with sickle cell disease. I can't tell you how many times I have very knowledgeable, well-intentioned, well-meaning providers say, can I really give morphine to a 1-year-old? I don't really feel comfortable with that because I haven't done it. And I say, that's what they need. It's safe, it's what they need. And so, empowering parents also to be able to advocate for their children in that regard is really important. But then having that physician partner or that healthcare provider partner to help you advocate is incredibly important.
So
now,
I'm sorry, go ahead.
So imagine then, you have a disease that unfortunately the best treatment that we have for the main manifestation is opioids. In the current, you've had that, you have patients who have for whom their bodies have been seeing opioids for 18, 19, 20 years, going to adult emergency rooms. And in many cases, these patients are more knowledgeable about opioids and the side effects and how it works on their bodies than the providers that they're seeing. In our current, and it goes without saying that many of these patients are Black and brown.
Correct.
So you take all of this this situation and it's yielded an enormous amount of discrimination against adults with sickle cell disease who present to the emergency room for pain.
I think that you pretty much summed up the 3 main categories. Lack of education from well-meaning physicians, because we all have not had the opportunity to take care of sickle cell patients. I actually did at Grady Hospital in Atlanta, so I understand how they were treated and some of the rebuffs that they receive on certain on the internal medicine service, unfortunately. And even in medical school, we read about it, but until you've taken care of a sickle cell patient, do you really understand the challenges? And also, I think that part of the challenge too is that, again, they've been having this disease process since birth. They've been in and out of the hospital, so you also have some power struggle. And unfortunately, some physicians don't take well to that. And so it begins to have another dynamic that inhibits or prevents good management, as we say, or interferes with quality of care. The other thing you said was the fact we've got education. We also have pain and control of pain, even as much as a 6-month-old getting morphine being questioned when we know what disease the child has. There's records about the child having this or the infant having this and still getting some resistance, because we are in this world where opioids are bad. We've had to control for them. And that's not new. I think I was looking back over the literature, and since the 1980s and this war on drugs and the crack epidemic, the sickle cell patients have been the most affected by not receiving or having limitations placed on them. And they actually have a reason for the high dose of medicines that they need. So, and then they have to constantly battle being viewed as drug seekers. When, like you said, this is what their treatment protocol requires. Is there any other treatment?
Absolutely. So, first of all, as a pediatric hematologist, and I would say many adult hematologists who are knowledgeable about sickle cell disease as well, we try and employ a large variety of therapies. So certainly opioids can be effective, and they can be incredibly useful. But they should be used in concert with anti-inflammatories, for example, with topical therapies like heat and topical anesthetics. they should also be used with, we're really trying to get into mindfulness practice.
Mm.
And so visualization, calming techniques, because all of these things, having your mind in the right place when you're feeling at your worst,
Mm-hmm.
really important for helping you get back to feeling your best.
Mm-hmm. What is the role of, can you hear me okay?
All of these things together
Mm-hmm.
become, yes, yes.
Mm-hmm.
Please go ahead. What?
No, I think we had lost out a little bit. I think I had my connection. But my question, you said mindfulness, and you take it from there.
Okay. So mindfulness, we're really learning a lot about how mindfulness practices can be really important in managing persons who have recurrent or even chronic pain. Unfortunately, many persons with sickle cell disease experience some degree of pain every single day. And I mean, the things that I see my kids with sickle cell disease and the adults that I know with sickle cell disease, the things that I see them achieve despite that is just humbling. And it's one of the things that motivates me to continue to work in this field, because they are working so hard every day to be normal, functional, productive, happy, well-adjusted people. And so mindfulness is a really important partner with opioids. I think the wrong thing to do for persons with sickle cell disease is just to give them unlimited access to opioids without the additional practices of using what we know about the physiology of the disease to incorporate other pharmacologic therapies, and also to employ mindfulness, to employ coping skills, distraction skills work great for kids, to employ the full breadth of what we have to really get at this terrible pain.
Let me ask you this. What is the role of, so the time that I trained, the role of transfusions and hydroxyurea?
Yeah.
What's the update on that?
So transfusions and hydroxyurea have been the mainstay of therapy.
Okay.
Hydroxyurea has been used now for over 40, nearing 50 years in adults, and for decades in children as well, really as a disease modifying agent. So I mentioned that part of sickle cell disease is that the red blood cells take on an abnormal shape in certain conditions in the body. Hydroxyurea prevents that shape change from happening.
Okay.
And so we've learned that hydroxyurea can safely be given to children as young as 9 months of age.
Oh, okay.
In some cases, we're even giving hydroxyurea to children as young as 6 months of age. What we've learned is that early initiation of hydroxyurea can prevent some of the long-term complications. It can also prevent short-term complications. Children who are on hydroxyurea are less likely to have frequent pain crises. They're less likely to have lung complications, or the main one we think of is called acute chest syndrome. They have fewer hospitalizations. So it's really been a workhorse for persons with sickle cell disease. Unfortunately, we still haven't been able to get universal broad adoption of hydroxyurea.
Oh, really?
Yeah. There's still a lot of concern and reticence for some families to use hydroxyurea. And I think I would encourage, families to just really engage with their provider, engage with their hematologist about why and how it works. There's a lot of misinformation that persists about hydroxyurea that we really have to work to overcome still.
So you think it's a pushback from the parents and not the providers, as if wow.
There's certainly pushback from some parents. There's certainly pushback, reluctance from some providers. So hydroxyurea first emerged as a medication to treat some types of cancer.
Yeah. Okay.
And so there are a lot of general practitioners, whether they be pediatricians or adult medicine providers, who are just uncomfortable using a cancer therapy.
Cancer drug, they hear cancer. I got you.
People hear cancer, and that creates nervousness both on the provider side and on the parent side.
I understand.
I say, have a conversation about it, and learn about it. And then also, we need to create spaces. We have created spaces. The internet has created spaces where you can hear from other patients about how it's helped them and whatnot. But, as a pediatric hematologist, I'm a pediatric hematologist oncologist, so I feel very comfortable providing it. But there's certainly many places in the country where patients don't have access to a pediatric hematologist oncologist, and so don't have access to a provider who feels comfortable using hydroxyurea as we do.
Wow, that's amazing. So honestly speaking, what's the life expectancy of a patient with sickle cell anemia?
So this is a tragedy in sickle cell disease. The average life expectancy is still about 50 to 60. And we really haven't budged much in the last 30 or 40 years.
That's right.
We've made amazing strides in pediatrics.
Yes.
So, the earliest large population studies that I can think of from the 1970s.
That's right.
About 75% of children surviving to adulthood, 75%. And now it's, above 95, 90, 96, 97% of children get to becoming adults. But that period from when you're 18 to 21 to the later adulthood, we still haven't been able to provide the same level of care to adults with sickle cell disease as we have to children with sickle cell disease. And it's really, really tragic.
Well, I think that we still have to face some of the social determinants of health, environment, education, and they become big influences that you, as well-intentioned as you are in all the research, can't ultimately control for every patient. That would be wonderful to be able to do that. But of course, those determinants that that conversation about COVID has brought out, I'm sure weighs in on your population as well.
It absolutely does. And it's kind of the perfect storm. The way that I think about sickle cell disease is sort of injury by 1,000 cuts. You have these injuries, these red blood cells that have taken on the abnormal shape. These cause these small injuries to your entire body over the course of life. So, when you're 6 months old, you don't really have a lot of injuries, but little injuries continue to happen. So that by the time you are 20 years old and these injuries have been happening for 20 years, now your body is starting to really feel the effects. So we know that sickle cell disease tends to be progressive.
Yes.
And at the same time as that disease starts to become more progressive, becomes more apparent, then the needs of our young adults change, and those social determinants of health become even more pressing. And I mean, it's really tragic. We learned many years ago that the average life expectancy, as I said, is 50 to 60. But there's actually a spike of mortality, a spike in the rate of death in the mid-20s.
Oh, okay.
And it's that transition from pediatric care to adult care at the same time. Social determinants of health, young adults are transitioning to independence. Yes. And it's happening at the same time as the disease is starting to really get worse. I mean, it's a perfect storm, but as pediatricians and actually with our adult hematology partners, we're really leaning into this transitional period and really trying to focus on and using some research, but trying to focus on how can we provide better care in that, to bridge that gap so that our children and young adults can really get into adulthood and continue to thrive as they've done as children.
So let me ask you this question. Are these kids, once they transition from 18 into adulthood, do they lose insurance coverage?
Many of them do. And so, the changes in our national insurance policies with the
Chips.
CARE Act. That's made insurance more available to a lot of young adults.
Wonderful.
And that's been incredibly helpful.
Helpful. Okay.
But losing insurance is a huge issue. But you talk to a lot of parents, and a lot of parents are very protective of their children with sickle cell disease, because they've been dealing with the disease for their entire lives. And we really have to coach a lot of parents. Remember, when this child turns 18, they have to be prepared to do this without you.
Oh.
And so, we've had parents who've been driving the care and really just loving on their children as parents should and do for so many years. All of a sudden you get to be adult care, and your parent can't be there to when the doctor asks you, what are your medicines? Your parent isn't there to answer for you. And so we have to really make sure that our kids are prepared for that transition. You also have the situation in a lot of cases, and particularly in places that have a large sickle cell center, where you have a child who's been seen by the same provider at the same hospital by the same team for 18 or 22 years.
Wow. Yes.
Then they have to find a new team. They have to rebuild that trust, and it's almost like, it's a really hard transition for so many of our patients. They say like they're getting kicked out of their home.
Yeah. I thought you would see them past 18. That's not true.
So it varies from hospital to hospital. In our hospital, we can actually see them up to age 22.
22. Okay.
No, even then, it's really hard.
Oh my God. Oh, wow. That's something to really think about. It is. To lose that continuity and family, and to rebuild trust, that is such a challenge. So the sickle cell patient have so many challenges, that is, like you said, that could be another hour of conversation, but we have to recognize that. What about your challenges with the COVID pandemic and taking care of your patients?
It has been a huge challenge. So I mentioned that part of sickle cell disease, although we think about it as a red blood cell disorder, there's a huge component of inflammation in sickle cell. And so you take a body that already has underlying inflammation, and you add COVID, which is an inflammatory disorder, and you have just a much more severe manifestation of COVID.
Yes.
One of the leading complications, one of the leading causes of death for persons with sickle cell disease, or the leading cause of death for persons with sickle cell disease, is something called acute chest syndrome. And this is basically pneumonia in a person with sickle cell disease, but the pneumonia causes more sickling, or more of that red blood cell change that causes more complications of sickle cell. What are people with COVID getting hospitalized for? COVID pneumonia.
That's correct.
And so again, this combination has been really, really challenging for a lot of our children and adults with sickle cell disease. The CDC, as they started to roll out groups that should be thought of as high risk for complications of COVID, persons with sickle cell disease were among the top of groups that we should be concerned with. So, so we, the providers and the people who cared for people with sickle cell disease, understood this. People with sickle cell disease understood this, and yet, as we have, as our country has evolved in this pandemic, and with its understanding of the pandemic and the regulations that have come with the pandemic, there have been so many questions about protecting people with sickle cell disease. I today, and in this moment, our parents are terrified about sending their children back to school unvaccinated.
Okay, so so we have the talk about just the disease process in a patient, but prevention. So are we, how are you advocating for vaccinations in your patient population?
I I strongly recommend vaccination for people with sickle cell disease in general, for everybody who has a vaccine available to them. So that would be everybody who is over 20 years of age. Now, obviously, you should be talking with your own provider about the different vaccines and what may or may not be right for you. But in general, because COVID has such bad outcomes for persons with sickle cell disease, everything that we can do to prevent that outcome should be done.
It should be done. Okay, so you're encouraging all your patients who can get vaccinated to get vaccinated.
Yes, and I absolutely recognize that this needs to be a personal conversation with your provider. But so I guess the best blanket recommendation that I could give is to say, please go and talk to your provider about getting vaccinated for sickle cell disease.
And it also includes their families and their households as well, to have that serious conversation about the risk of COVID. Okay.
Right, because there are many children under age 12 who can't get vaccinated.
Yes.
Prevention for them is to not bring COVID into the house. So everybody in the family should be getting vaccinated against COVID as well. We're also, encouraging everybody to continue to wear masks in spaces, continue to practice good hand hygiene, continue to practice social distancing. But really, the game changer in this pandemic has been vaccination.
And are your patients also encouraged to get the flu shot? Because the flu season is going to be coming up as well. So is that also part of the vaccinations that you encourage for your sickle cell patients?
Absolutely. Every year and for always, because the flu causes pneumonia.
Yes.
And, pneumonia and sickle cell disease is one of the leading causes of death. So we don't want our kids to have severe respiratory illnesses. So yes, we also recommend. I recommend the flu vaccine to all of my patients. And again, I would encourage all patients to talk to their own providers about the flu vaccine.
Let me ask you this. You wrote an interesting paper about the checking for sickle cell trait for athletes, NCAA requirements, and also the Department of Defense. What was the focus of that paper again?
So, that was a really interesting evolution. And so in the military, as well as in college sports, those athletes and those servicemen and women, they work really, really hard. What was seen in before this was mandated was that there were a group of people who were suddenly dying of heat exhaustion or heat related complications, or for reasons that were unknown. And it came to be understood that persons who have sickle cell trait were more at risk for these heat related complications than persons without sickle cell trait. And as a result, both the NCAA, well, first the Department of Defense and later the NCAA began to require testing for sickle cell trait as a requirement for participation, so that they would have that knowledge. Now, certainly at the same time, they also modified their regulations so that everyone could be protected from heat exhaustion and from complications of dehydration. But that was particularly a challenge for persons with sickle cell trait. I mentioned that many years ago, in the mid 2000s, actually, it took it in the 2000s, that we actually started screening every child who's born in the United States for sickle cell disease.
Okay.
But, you tell a new parent that your child has a genetic disorder that's not going to affect them, may affect their children, your grandchildren. And what we've learned is that a lot of parents just forget. It's not something that they have to think about for 18 years, and then it gets forgotten. So I think that the reason that now when they do need that information in college, the NCAA and the Department of Defense repeat that testing.
They want to repeat the test. Yeah. Okay, even today. So I do have a college kid and they wanted the test repeated. And I'm like, it doesn't change, does it? I mean, like, but again, they're like, okay, just to make it fair for everybody and for people, when we have kids that are coming from international countries where that's not mandatory.
Absolutely,
Okay.
absolutely. So this is another passion of mine that particularly I've had the opportunity to work with the American Society of Hematology
Okay.
to support the development of newborn screening programs across sub-Saharan Africa.
So tell us about some of your work in Africa, and some of your future goals.
Yeah. So I mentioned that my parents are from Liberia, and so when I had an opportunity to go back to Liberia as a pediatrics resident, I jumped at it, and
Mhm.
this is my first time being back in Liberia. I'd had opportunities to work outside of the United States in medicine before that, but this was really special.
Mhm.
And so I went back in the first month I went back. I mean, it was shocking in so many ways.
Mhm.
But you know, as I reflected on that time, I thought I didn't see any kids with sickle cell disease.
Mm.
What I knew about sickle cell disease, that was very, very strange.
Mhm.
So, you know, on an epidemiology basis, on the population basis,
Mhm.
75%, more than 75% of
Mhm.
infants who are born with sickle cell disease are born in sub-Saharan Africa.
Mhm.
There are about 400,000 children born with sickle cell disease across in the world every year.
Okay, 400,000. Mhm.
And some countries, I mean, for example, in the country of Nigeria, there are an estimated 150,000 children born with sickle cell disease each year.
Oh, wow.
Compare that with what we talked about in the United States.
2,000, yes.
So the scope of the challenge is so much greater.
Mhm.
I just thought, how can I be here and not see children with sickle cell disease?
Okay.
And the answer was that the mortality there for children with sickle cell disease is so much higher.
Mm.
We've made quite a bit of progress, but in the 1970s, there were studies that were done to try and look at sickle cell disease in sub-Saharan Africa, and at that time, it was estimated that about 90 to 98% of children with sickle cell disease would die before they were 5.
Oh, wow.
So, I mean, you know, we've learned that it's largely because those children are not getting diagnosed at birth.
Mhm.
They're dying from infections because since they're not getting diagnosed at birth, they're not getting put on antibiotics,
Mhm.
not getting all the vaccines that they need to be getting as infants.
Mhm.
Their parents don't have the knowledge to advocate for them properly when they do get sick with
Mm.
complications. And so the mortality is just incredibly high. Even today, in many countries in sub-Saharan Africa, the mortality for childhood mortality for sickle cell disease is on the order of 50 to 80%.
Mm. Wow.
So we have a lot of work to do. You know, the challenges are not insignificant. I think recently Nigeria made a national policy
Mhm.
that advocates for newborn screening for sickle cell disease. And they're still in the early stages of implementation, such that I don't believe it's happening for every child yet, but they're on their way. But really, they are. That's the only country that I'm aware of
Mhm.
where they've even gotten that far. So, in partnership with the American Society of Hematology, we're really trying to uh,
Mhm.
use regional partnerships in
Yeah.
different countries in sub-Saharan Africa, as
Mhm.
well as what we call North-South partnerships with, you know, one of the largest organizations for hematologists in the world,
Mhm.
partnering with hematologists in countries in sub-Saharan Africa and with the ministries of health to
Mhm.
really figure out how to deploy newborn screening so that we can give these kids a chance.
So the question becomes, once you know, we always say in medicine, if you ask the question, be prepared for the answer.
Yes.
So once you start asking the question of who has it, who doesn't, now we have to ask the second question, or do we have treatment available? And is this where it always comes down to an issue about funding and resources? Are those some of the challenges you're facing?
Absolutely. So, we spoke about how hydroxyurea is really a workhorse for sickle cell disease. Until very recently, hydroxyurea, although it's a very old medication, so in the United States, it's incredibly cheap. Until very recently, hydroxyurea was easily 10 or 15 times more expensive in sub-Saharan Africa, where personal income and where there's so many more people who are in deep poverty than in the United States, that it was just not feasible to prescribe.
Wow.
So at the same time, we're trying to ask the question of who has sickle cell disease and who needs these resources and this advocacy. We're also trying to ask the question, how can we make hydroxyurea and other therapies more available? How can we increase the access to blood supply? How can we, another new opportunity and exciting opportunity for sickle cell disease is that, in the last 10 or 15 years, many more pharmaceutical companies have started to really think and focus on sickle cell disease. So as an example, hydroxyurea was approved for use in children in 2006, around 2000s, early 2000s. The next drug to get approved for sickle cell disease wasn't approved until 2018. So, I mean, just almost 20 years between the first drug getting approved and the next drug getting approved.
Yeah, that's true.
The third and fourth drugs got approved in 2019. Or I'm off by the years. The first hydroxyurea was the late 90s. The next drug was 2017. The next two drugs were 2019.
Okay.
So it kind of gives you a sense of how quickly things are starting to move. Now we've had a couple of years without much new, but people are starting to think about this and focus on this. And I really have to credit some of the pharmaceutical companies that I've worked with, that they're really being thoughtful about how can we actually get this drug to where it's needed. If 75% of the people with the disease live in sub-Saharan Africa, we really have to think about how do we get it to sub-Saharan Africa, in addition to serving persons with sickle cell disease in high-income nations like the US and Europe.
And in comes COVID, as they say. So you get this perfect storm against all of the progress that you and other researchers like yourself have made. So I think that there's still so much information that we could cover, but I'm gonna end there in the fact that I want you to stay encouraged, even in the face of COVID. I know that Texas and Houston in particular, and all really around the state, have had an uptick in COVID. And we have to remember that there are vulnerable populations, cancer patients, sickle cell patients. This is September, and it is recognized as Sickle Cell Awareness Month. So we're going to try to get information out there about this disease that you've been so passionate about to our readers and our viewers. And I'll check back in with you when I'm in Houston. Okay.
Please do. And thank you so much for the opportunity to chat with you today and to celebrate the sickle cell disease and celebrate our patients with sickle cell disease. And you're right. As we're getting through this pandemic, it really is a team effort.
It is.
We really need to lean on each other, lean on our communities, and really remember that all of our choices are really having an impact on our entire community, and work together to get through this so that we can get back to
normalcy. I don't know.
To some kind of
normalcy.
Hi, Zuma family.
Thank you, Dr. Tubman.
If you like what you're seeing and what you're hearing, subscribe to our channel. Hit the bell icon below to be notified of our recent videos. What the doctor say?